in 2019, we had a national health interview survey that found that 20% of all US adults had chronic pain. It's 50 million people. And of that group, 77.4% of adults had high impact chronic pain, where their chronic pain was affecting their activities of daily living on a significant level. The survey also found that chronic pain increases with age. It's highest in patients who are 65 years and older, highest incidence in rural areas, and the total lost productivity is nearly $300 billion annually. So some just fun stats to start us off. And then here's a real patient of mine. DL is a 68-year-old patient with history of multiple myeloma, pulmonary embolism, anemia, coronary artery disease, COPD, on 3 liters of oxygen via nasal cannula. This patient had chronic low back pain and chemotherapy-induced peripheral neuropathy in their feet and their hands. So pretty complicated medical picture. And we're going to go through more about this patient throughout the presentation. They were currently taking hydromorphone 4 milligrams orally every 6 hours around the clock, pregabalin 300 milligrams twice a day, and duloxetine 60 milligrams twice a day. And I'll just tell you too, kind of like how my pharmacist brain works. Every time I look at a patient's med list, and this is what I always encourage our students to do, either in the doctor of pharmacy program that I teach in or in the pain medicine master's program that I teach in, which I teach several courses in that program, is like just always have this constant radar in my brain of like, all right, is this appropriate? What is here that shouldn't be here on a med list? What is missing from the med list that should be here? Is there any room to go up on medications? Is there anything we haven't thought of or anything we haven't tried? So even just reading this case, my brain is starting to do that. So I'll look at this and say, all right, hydromorphone around the clock. It's a short acting. It's not a long acting. They're taking it scheduled. They're not taking it PRN. Their pregabalin, also known as Lyrica, is maxed out. There's no room to go up on that if I wanted to. Their duloxetine is maxed out. And then they're also on lorazepam. This patient would take lorazepam as needed for anxiety, because what would happen was when his oxygen would fall, if his O2 sat would fall, it would cause, if he ever had an anxiety attack for another reason, it would cause his O2 sat to fall. So it's really important that his anxiety was also managed so that he didn't have too much of a significant drop in his oxygen saturation levels. And then he had tried some other medications, some topicals that didn't really do too much, a capsaicin cream, a lidocaine ointment, because his real primary concern was the neuropathy in his feet and his hands from previous rounds of chemotherapy. And then we have the PEG score, which I'll talk about in a little bit, but it stands for pain, enjoyment, and enjoyment of life and general activity. And he rated his pain an 8 out of 10, whether or not his pain interferes with enjoyment of life, a 10 out of 10. And then for general activity, he wasn't really able to rate it. Classifies his pain as burning in quality, and it's aggravated by physical activity, alleviated by meds. And the goals of therapy, which are really important whenever we're doing a pain assessment, and we'll talk about that more, is pain relief and his ability to increase his activities of daily living.